gonna try to keep this interesting because I know this is a tough spot. I always get like talk after lunch. I don't know why people do this to me, but I'm gonna do my best to keep you engaged. So the reason why I wanted to talk about this topic, sodium disorders, I really shouldn't have said neurocritical care patient because it really pertains to neuro patients across the spectrum. But this interest actually just started with me as a bedside nurse. I wanted to know why the heck we have to check sodiums every 4 to 6 hours on my patients, and it was actually just more tedious, and I really wanted to understand why. So it's something that's always interested me, and I hope that you can get something out of this today. So my objectives are to discuss why sodium is so important in neuro patients, and then go through some common disorders that affect sodium balance in these neuro patients. I don't have any conflicts of interest or disclosures. Nobody pays me to talk about this. Okay, so why is sodium so important in neurocritical care patients? Patients with neurologic injury commonly acquire changes in their sodium levels. We check it all the time. We're always wondering what it is. More commonly, hypernatremia is an issue, and partly due to the fact that we actually induce hyponatremia in a lot of our patients, and I'll get to that later. But also it's so important because of the effect that sodium has on cerebral volume. Quick changes can lead to serious complications, and shifts in water and sodium from the intracellular and extracellular space can cause neuronal swelling and shrinkage. So it's really important to understand why these levels are changing and kind of work through it. So I'm going to talk about SIADH and cerebral salt wasting, two disorders of hyponatremia. I'm sure many of you have heard these terms before, but I want to break them down and just try to help you understand a little bit more about each of these disorders. So what is SIADH? So it's really a disorder of impaired water excretion. It's the inability of the body, or I should say the inability to suppress the secretion of the antidiuretic hormone. It is the most common cause of hyponatremia you'll see in your patients. But to really understand it, you really need to understand first what ADH is. ADH is antidiuretic hormone. You may also know it as arginine vasopressin. It's a hormone found in most mammals. It's made in the hypothalamus and released by the posterior pituitary. Its function is to help us retain water in the body, and it also constricts blood vessels. This is a little picture that helps to understand if the pituitary gland, as your body level of water increases, you make and release ADH from the pituitary gland. As your body level of water reduces, you become thirsty. Your pituitary gland makes more ADH and works on the kidneys to preserve water. So this picture actually is kind of like what helped me understand hyponatremia and SIADH the most. I'm a very visual learner, so I think this helps. What you see here is enhanced water reabsorption leading to dilutional hyponatremia. So on the left, you see a patient without hyponatremia. You've got not so uneven of a balance of water and sodium. So really, this is the problem is a dilutional hyponatremia. So you've got water excess. You might hear it referred to as water intoxication at times. There's many causes. There's a lot of risk factors in our neuro patients, and it, depending on the environment you work in, where you've seen it, it may be, for example, in the ICU, we see patients with sodium problems, SIADH and pituitary surgeries, malignancies, after surgical procedures, but you can also see it with malignancies, chronic lung diseases. I guess the best way, and we're going to break it down as I go on, how to determine the etiology of your patient's hyponatremia is to think about a few key things. So you're going to look at clinical features, you're going to look at laboratory findings, and your symptoms really are going to be based on the development and the severity of hyponatremia. Somebody that has a sodium level acutely of 120 is going to look differently than somebody who's chronically had hyponatremia and has been that way for a while. So chronic, meaning that it's developed over greater than 48 hours. You might see dizziness, some forgetfulness, confusion, and then more severe symptoms such as seizure, coma, respiratory arrest. That's the kind of stuff that we are used to seeing in the ICU setting. So to diagnose, you want to look at a few criteria. You want to exclude other diseases such as renal or adrenal or other endocrine diseases. And you're going to see a few key things: hypoosmolar hyponatremia, so your osmolarity is going to be low. You're going to see concentrated urine, and you're going to see high urine sodium. You're also going to see decreased urinary output and potentially weight gain on patients. You're going to look at the lab criteria. I'm not going to go through the exact numbers because they do tend to vary slightly based on which institution you work for, what the reference ranges are, but you just get the gist of it with the fact that there will be hyponatremia, your osm will be low in your plasma, it will be high in your urine, and you will have high sodium levels in your urine as well. I like decision trees. They help me, algorithms. I'm a very visual learner, so I put a couple of these in here to help you kind of walk through it. So, you can start by something as simple when you see somebody with low sodium is check their serum osmolality and go from there and kind of help you break down what you're gonna do from there. And as I get through it, you'll see a key point that I'd like to mention with all these disorders is to try to understand the patient's volume status. It's going to be really important in helping you determine where you go. This one's kind of busy, but this is also another decision tree that can help us, and it kind of branches out here, and this is why I mentioned volume state, because just depending on whether the patient is hypervolemic, euvolemic, or hypovolemic, it's going to kind of help you walk through the treatment. So I'm going to talk next about cerebral salt wasting, but it's very confusing to me for a long time, and I just like to put things up here just to try to help you break it down. And again, the volume status is going to be a big determinant. Both disorders of low sodium and somebody that has cerebral salt wasting, their volume state is decreased, and in SIADH it's normal or increased, and then so on and so forth. You can see some of these values here. So when you want to look for treatment of SIADH, you want to clearly identify the problem and know what you're treating. You want to treat the underlying disease if possible. What we tend to do is fluid restrict patients, especially in the ICU setting. We use things like intravenous saline. We typically don't use hypertonic saline because, again, it's more of a water intoxication state or a dilutional hyponatremia, so you don't necessarily want to be replacing with hypertonic saline. We also use vasopressin antagonists such as conivaptan, tolvaptan, not so common, but it is used. And then demeclocycline is something we also use that helps basically promote water excretion. So it's actually an antibiotic, but it's used off-label to help us. So the rate of correction is going to be based on the chronicity, and the exact numbers or how fast you do it. It varies again amongst institutions, but you want to kind of keep in mind that if it's a more chronic problem, you're going to go a little slower versus somebody that has an acute hyponatremia that has some of those more severe symptoms that they could really decompensate quickly from. And usually when we're correcting somebody in the ICU setting, we're monitoring their sodium every couple of hours for, I say 2 to 3 hours here, but in reality it's not really feasible because when you're wanting to check it that quickly, you don't even have one back before you send another one. So the key points, though, are that hyponatremia in SIADH is a result of excess of water, not a true deficiency of sodium. Typically all cases of hyponatremia in neuro patients are due to SIADH, and even mild hyponatremia can be associated with increased mortality. So cerebral salt wasting is another disease process that we see in neuro ICU most frequently. It's not as common as we might think, but I think most of you will relate to it when you think of your subarachnoid hemorrhage patients. Really, it was discovered in the 1950s, right after the discovery of SIADH. And for many years, SIADH was thought to be the culprit for hyponatremia in these patients until we started to see the difference in which would be hyponatremia in the setting of hypovolemia, whereas in SIADH, we're talking about normal or even increased volume state. It can happen in patients with subarachnoid hemorrhage. It can also happen in patients with TBI as well. There's two major theories behind this: the sympathetic nervous system hypothesis and also the natriuretic peptide hypothesis, but they both involve changes in the renin, angiotensin, aldosterone system. So with the sympathetic nervous system hypothesis, the theory is there's a loss or decrease of adrenergic tone to the nephron after neurologic injury that leads to major consequences, which is decreased renin secretion causing lower levels of aldosterone and decreased sodium reabsorption at the proximal convoluted tubule, and also dilation of efferent arteriole leading to increased filtration of plasma and sodium. But there's a flaw. In general, CNS injury leads to surge of sympathetic tone. And the natriuretic peptide theory is something that I probably wouldn't really think about because we don't routinely check these peptides in our patients if we're thinking they have cerebral salt wasting, but it is something that was identified that it actually is considered there's an increase in these peptides, particularly the ANP and BNP in these neuro patients. They normally antagonize that renin, angiotensin, aldosterone system and promote vascular relaxation and inhibit generation of vasoconstrictor peptides. So the theory suggests an increase in peptides after CNS injury. How do we distinguish cerebral salt wasting in the clinical setting? This is just another picture that kind of helps you to determine and walk through the differences because you're dealing with two disorders of hyponatremia and you're trying to distinguish what's causing it. So you're going to look at a couple key things, which is volume. Again, volume state is usually the first thing I go to. Salt balance, your urine output, and then you're going to look at serum sodium and osmolarity and also some of those levels in the urine. But even though I mentioned these values, half the time we don't even need to check all these. If you think about working with some of these patients, I don't often order these labs for all patients. Sometimes you can tell just by kind of breaking down some key things. What is their sodium level? What is their history? What is their volume state? Again, I can't stress that enough. So it's difficult, though, to accurately determine this in patients. It requires looking at the whole picture. You can look at other lab values, such as their BUN and their creatinine. Have they been vomiting? Do they have, accurate INO measurements, body weight? In the ICU setting, you can also look at blood pressure, CVP, and less frequently we use wedge pressures. The treatment is to restore intravascular volume. So you want to correct the hyponatremia. And we will use, in less severe cases, salt tabs, although they're not really that great to use, especially in the ICU setting. They make people sick to their stomach. They make people vomit. So you'll see sometimes the addition of Florinef, and you can also see, in some cases, in more advanced cases, we'll use the hypertonic saline. If you really want to restore volume, that somebody's had a really high urine output, you can use a lower, like 2% sodium. We'll use 3% a lot, and you're just going to be frequently checking that sodium. And there isn't really any good guidelines to really tell us how to dose these. I know that one of our neurointensivists uses sort of an algorithm to help us decide if the sodium is this, adjust this, but unfortunately it's really based off of your judgment because there aren't really good guidelines to help us determine the rate of correction or how we should dose these hypertonic salines. And then to switch gears, so now we've just talked about two disorders of low sodium. I'm going to mention 1.5, sort of iatrogenic. I don't know if I want to call an actual disorder, but it is something that we do for reasons that are important here. So the causes of hypernatremia most frequently seen in these patients, iatrogenic, meaning we promote high sodiums in a lot of patients that have injuries. And I'll get to that on the next slide, but that can be done through use of hypertonic saline and also hyperosmolar therapy with mannitol. And then there are also surgical and medical reasons for hypernatremia. You can have diabetes insipidus, central DI, traumatic brain injury, pituitary surgery, which I mentioned before, and medical things such as drugs that induce it and acute kidney injury. So iatrogenic, why? We do this to reduce cerebral edema for many reasons. Our stroke patients, our TBI patients, patients with hemorrhages. We give a lot of hypertonic saline to patients that have ICP problems to help us sort of shrink those cells and reduce that cerebral edema. But it isn't a benign process. It does carry risks, and it can have adverse effects to it, so you really have to use caution when intentionally trying to increase somebody's sodium. And again, it's difficult because there aren't actual guidelines to really tell us when should we start lowering somebody's sodium, how should we do it, how quickly can we do it. I know, sometimes people are afraid when I order D5W on one of my patients to lower a sodium of 160, and I'll tell you those are like extreme cases when, say, I have somebody that's going to be a donor and we've declared brain death and we're not worried about those sudden shifts and rebound cerebral edema, so you can do things faster. Typically, what we do in the ICU setting is just cease the use of hypertonic saline and then see if the sodium will start to come down. And then careful initiation of free water back to the patient if it's not bringing that sodium down. And diabetes insipidus, so DI is a condition that you can characterize with excessive thirst, large amounts of severely diluted urine. There are two major forms of it. There's central DI, there's nephrogenic DI. I'm going to mainly just talk about central DI today. Nephrogenic DI, though, it can be a familial X-linked trait. It can be acquired with infections, pyelonephritis. You can see it in sickle cell anemia. It's normal secretion of ADH, but varying degrees of renal resistance to the water retaining effects. Central DI, also called neurogenic DI, is what we're used to seeing. It's deficient secretion of ADH. So it can be induced by trauma. It can be induced, you see it most of the time with pituitary surgeries or even hypoxic ischemic events. You see it, it's almost kind of a ominous sign when you see it in our patients that are progressing to brain death. It's sort of that, they went into DI. I think they might have progressed. So it can be mild, moderate, severe. Central DI, again, is caused by the decreased amount of ADH. The kidneys are unable to conserve water as they perform their function of filtering blood. Again, the causes and risk factors, so you've got idiopathic causes, you've got trauma, pituitary surgery, and hypoxic events. I put the raccoon here because that's my sort of symbol for TBI or basilar skull fracture, so you get the raccoon eyes from it. I don't know if anybody caught that, but that's just me. I love animals. Okay. So clinical features and presentation of somebody with DI, you're going to see polydipsia, polyuria, weight loss, fatigue, dizziness, changes in levels of consciousness, elevated temperature, tachycardia, hypotension, and poor skin turgor. A lot of times, I'll be honest with you, in the ICU setting, it happens so quickly, I'm not like, whoa, they're like tenting, You see like liters and liters, and the nurses coming to me saying, oh my God, they're peeing a ton, I don't know what to do. So it's usually pretty obvious. It looks like somebody's just dumping water. And it can be, that can be just the basic telltale sign for these patients that are really sick, that are intubated and are not saying, oh, I'm thirsty. In some of the less severe cases, or even just patients that we're watching on the neuro floors, we try to encourage them to replace the water that they're losing drinking it. But in the ICU setting, a lot of times we have to use intravenous fluids. So the lab criteria or the diagnosis for DI would be hypernatremia. You've got hyperosmotic plasma, so your osm in your blood is elevated, and you've got low osm in your urine, and then a low specific gravity. This is just sort of a busy diagnostic approach. I don't know if you'll have access to these slides, but I'm a visual learner, so I like algorithms. And this is another one that helps you decide. One of the things that I find interesting is DDAVP, which obviously we use to treat DI. If it's the nephrogenic DI, you're not going to really have a response to that DDAVP. So that's kind of going to help you determine. Again, DI management, you're going to fluid replace. You're going to estimate the patient's free water deficit. In a patient that's awake and able to, you're going to encourage them to drink water. And you're going to try to help them keep up with it. In more severe cases, the patient cannot do that. Even if you tell them to keep calm and drink more water, they're not going to be able to. So we will use a lot of isotonic saline. You would think, in some cases, I would think, why not use hypotonic solution or a half normal saline, quarter. But really, you just need isotonic saline in the beginning just to replace that volume that patients have lost. And I think in the cases where patients are dumping liters and liters at a time, the whole, we can't correct it too quickly kind of goes out the window, because you have to replace that volume, because the more you lose, the sicker they're going to get, and you're going to deal with other things such as hypotension and potentially more ominous things. And then DDAVP, which is essentially desmopressin or the synthetic ADH, you're going to replace that. Because again, it's impaired secretion of ADH. So you can give this through multiple different avenues. You can do injectable solutions, tablets, and even nasal spray. In the ICU setting, I primarily use IV injection. And then dosing will vary depending on how you're going to give it. You can give it IV, you can give it subcutaneously, usually 2 to 4 mics in a day. But I'll be honest with you, I've given 4 mics, and then 4 mics again, and then 4 mics again, and I guess, it really depends on the case. So you use these dosing as more of guidelines. I like this picture because this kind of helps me. It's the pituitary gland with the wrench turning off the ADH, and the kidneys are just dumping water, because that's basically what you do when you have DI. Key points, DI is a primary defect in the secretion of ADH. You need to accurately measure I's and O's. After assessing fluid status and the sodium level, you treat the dehydration and the hypernatremia, again with the isotonic fluid most of the time, like a normal saline or water. But DDAVP will only be effective for those patients with central DI. And then I'm going to go through a case study. This is actually a patient that I took care of when I was back in Ohio. She's a 51-year-old woman that had a history of hyperlipidemia and came in with a suprasellar mass that was resected by neurosurgery with a small complication of a little hemorrhage, intracerebral hemorrhage in that surgical bed. She went to the post-anesthesia care unit, PACU, or step-down unit post-operatively, and was monitored, and the pathology was a non-secreting pituitary adenoma. So, seemingly benign. Surgery went well, other than that little complication with the hemorrhage in that bed. So on the 21st, she had 11 liters of urine output, which is a lot. This was all very quickly, within, I'd say, maybe 6 hours. Her sodium went up to 158, and she was diagnosed with frank post-surgical DI. We gave her 2 doses of vasopressin, or I should say desmopressin, each lasting 36 to 40 hours. She was stable for the next couple of days. And then you can see it 2 days later, you've got sodium trends 142, 147, 142, and an average urine output of 6 liters per day. A couple days later, you see sodium levels are getting kind of low, so they're heading down into the 120s, and her urinary output drops from 6 liters per day on average to 2 liters. Well, what's happening? So you can actually see sort of a triphasic response in some of these patients where you actually get a second phase, which is a sort of an SIADH lasting anywhere from 5 to 15 days. And why is this? Uninhibited release of ADH coming from those necrosing nerves on the pituitary stalk where that surgery was. So in this case, we're switching gears that we completely different from where we were treating her before with the desmopressin and giving her hypertonic saline, and also giving her fluid back as well. So a couple days later, her sodium is 140s. She's on hypertonic saline, and then it stopped, and she's transferred to the neuro ICU for changes in her level of consciousness, and her sodium dropped again to 129. She was restarted again on hypertonic saline with no improvement in her mental state. Why is this hypertonic saline necessary at this point? Typically, hyponatremia is self-limiting, and it doesn't become that severe. But in this case, because it's SIADH, the fluid restriction still would be the mainstay of treatment. So then on the 27th, you have the sodium she's going from 125 to 145 in a very short period of time, and her urine output picks up again. What do we have? We have DI again. And then we're back again to treating her with DDAVP and putting her on vasopressin and replacing that fluid. So really the stabilizing point was when we gave her the desmopressin, and at this point it gets real complex even in my mind, so we would ask endocrine to come help us. But there's treatment pearls of wisdom to treat not on the increased urine output, instead monitored for associated shifts in sodium levels. Otherwise, we can actually cause iatrogenic SIADH. And then a couple days later, this patient actually developed some cerebral vasospasm, was treated with verapamil, and developed acute onset of hypovolemic hyponatremia and did not respond to DDAVP. So that was really puzzling. We're thinking, what is going on? Well, we had cerebral salt wasting complicating DI. So two thoughts: the ICH potentially led to increased BNP, which goes back to where I talked about that natriuretic peptide theories, where there's an increase in those peptides with CNS injury. Possible low renin and aldosterone levels, we're not really sure. The patient was given Florinef and then usual DI management with DDAVP based off of her sodium and urine output. So in summary, you've got one patient with 3 physiologically distinct endocrinopathies with 3 different treatment regimens within a 3-week time span, stemming from the same initial illness. Highlights the complication of neuroendocrine connection, which really emphasizes that you need to think critically about these patients. You need to look at some of the key components, and not all patients look alike, so they're all different. Give them each that individualized attention. I don't know if they'll have access to these. Okay, because then again, this is a picture that really helped me kind of break it down, but it's very busy, so I'm going to let you look at that in your own time. And I put another chart in here as well to help you kind of break down the differences between some of these common states. I moved through that quicker than I thought I would.